This podcast does not provide medical nor legal advice. Please listen to the complete disclosure at the end of the recording.
Hello, possums, and welcome to Everyone Dies, the podcast where we talk about serious illness, dying, death, and bereavement. I'm Marianne Matzo, a nurse practitioner, and I use my experience from working as a nurse for 45 years to help answer your questions about what happens at the end of life.
And I'm Charlie Navarrete, an actor in New York City, and here to offer an every-person viewpoint to our podcast. We are both here because we believe that the more you know, the better prepared you are to make difficult decisions.
So please relax, get yourself something to eat and drink, and thank you for spending the next hour with Charlie and me for our discussion about what options are available in the presence of advanced cancer that is not responding to chemotherapy. In the first half, Charlie educates us about what a hot dish is and the formula, because, Charlie is a hot dish, and the formula to make a funeral lunch offering for the rest of your life. In the second half, I'm going to talk about the things that should be considered before continuing chemotherapy when the cancer has not been responsive to multiple chemotherapy drugs. And in the third half, Charlie chats about the power of music at the end of life. So Charlie, my hot dish friend.
Yeah.
What's all this fuss about the hot dish?
We're talking about a hot dish. Oh, well, if you go to any funeral lunch, you will likely see a table full of casseroles and Pyrex dishes. But are they casseroles or a hot dish? Hot dish, the unofficial state cuisine of Minnesota. Are our friends in Minnesota aware of this?
Very much so.
Well, if they weren't before, they will be now. Is a comfort food staple found in households across the upper Midwest. Incorporating a mixture of simple, thrifty ingredients and mix-it-together cooking techniques, it invokes a sense of nostalgia amongst fans. A creamy sauce binds three essential hot dish components together: starch, protein, and vegetable. You can watch the documentary, Minnesota Hot Dish, a love story. I'm laughing with you.
Yeah.
To learn all about this category of food. The Great Depression secured hot dish as a food staple and effective, affordable way of feeding entire families with canned food and limited meat. If you call spam limited meat. The word hot dish was first used in a 1930 Minnesotan cookbook published by the Grace Lutheran Ladies' Aid. This landmark recipe called for hamburger meat, onions, celery, canned peas, canned tomato soup, and cremettes, Minnesotan macaroni, all to be stirred together and baked. North Dakota.
I can remember my mother having cremettes in the cupboard, but I don't see them. I don't see them here in the South.
Actually,
so I wonder if they still make them?
I was going to say, I have not thought of cremettes in years. I don't know. I'm currently in Michigan, and if I have time before I take off today, I'll go check. I don't know. I mean, I'm on the East Coast now, so I don't know.
I don't know either.
It bears
inquiring minds want to know.
It bears an investigation. I'll shoot an email to 60 Minutes. Maybe this will interest them. Yes, so we moved on to North Dakota. North Dakota transplant and food blogger Molly Yee writes, if you were to place hot dish recipes on an XY chart where X equals how much it looks like barf and Y equals how delicious it is, they would be maxed out on both accounts. That's the charm of a hot dish. I do hope this is part of the recipe.
It is the recipe.
Very good. Despite its overwhelmingly beige aesthetic, hot dish is beloved for its convenience, economy, lack of pretense, and nostalgia. Recipes are passed down through parishes and families with as much gravity as oral histories. And while people love to love it, they might love making fun of this strange obsession even more. Stand-up comedian, her specialty is hot dish humor, and author Pat Dennis wrote Hot Dish to Die For, a collection of 6 mysteries in which hot dish is a choice weapon. Oh, wait, there's more. And edited Hot Dish Haiku. The book of poems explores native hot dish love. For example, herd of Lutherans running to church hot dishes, natural stampede. Brings a tear to my eye. Dennis describes the dish as a can of vegetables, can of cream of mushroom soup, white rice, and I got it on sale meat. And while
this really sounds like growing up in Michigan, I gotta tell you.
And while that might not be appealing, oh really? She says people love hot dish because it's not a food, but a memory.
It's true.
Yeah, it is true. The Tater Tot Hot Dish song expresses the same sentiment and goes like this. Gonna make a tater tot hot dish, gonna set my heart at ease. Gonna make a tater hot dish to review old memories. My mother made a tater hot dish and Grandma made it with a touch of cream. And even after years of fine dining, I still can taste it in my dreams.
It's so sweet.
Yes. And let's see, it's still time to submit it for this year's Pulitzer Awards. Hot dish may seem remarkably mundane, really, but it sparks heated competition, especially among Minnesotan politicians. The Minnesota Congressional Hot Dish Competition is held annually and stakes state senators and representatives against each other in a friendly food battle that's decided by a blind taste test. The winner takes home a plaque made from a glass casserole dish. It's always nice to put aside our differences and come together over some great hot dish. Former Senator Al Franken commented in a release following the 2016 event. For the record, his hot dish entry that year was a land of 10,000 calories hot dish. One of the most fun things about making hot dish probably is naming it afterwards. Here's a sample of some of the wackier hot dishes out there. Ketchup surprise hot dish. Back of the refrigerator hot dish. Turkey wiener doodah hot dish. Oregon meat cashew hot dish. Oregon gobble it up Minnesota hot dish. Suspend the rules and pass the hot dish. Hot tot per beer, maybe Burberry, dress well. Hot tot per beer tater dishinator. Drop it like it's hot dish. Please don't make me repeat this list. The basic formula is meat plus canned cream soup plus vegetables equals hot dish. This might have been inspired by Einstein. We don't know. Everything is thrown into casserole dish and baked until it is steaming hot and has a golden crust on top. How to Talk Minnesotan provides a starter recipe for generic hot dish that calls for 2 cans of cream of mushroom soup, 1 pound of cooked and pulverized meat, and 2 cans of notably nonspecific vegetables. The ingredients are combined in a large bowl and stirred. Add a little salt to your liking and pour everything into a dish. Top that with fried onions or some chow mein noodles and bake it at 400 degrees until a brown crust forms. So, for your next funeral lunch and everyone afterwards, you have the formula for a perfect hot dish to nourish the crowds of mourners. I know it's making me cry right now. Oh my
gosh.
please go to
That's too funny. I'm sorry, but it is hysterical.
So please go to our webpage for the multiple recipes for this week and additional resources for this program. Your tax-deductible donations are always welcome so that we can continue to offer you quality programming. Thank you in advance for making your donation at www.everyonedies.org. That's dies.org. Marianne?
Thank you for that, Charlie. That was really great. So, on a more serious note, I'm going to talk with you today about the process or the thinking process that you can use if you or somebody you love has a cancer diagnosis, has been on chemotherapy, and now there's a decision to be made. So let me tell you a story. About 6 months ago, Jamie was an active 66-year-old. She had a minor car accident that resulted in a pain in her rib, but long after it should have gone away, it continued to be sore. So they did an x-ray to evaluate this pain, and the result was suspicious, and her healthcare practitioner ordered additional testing that led to a diagnosis of non-small cell lung cancer. The first chemotherapy drug given is called first-line therapy, and for Jamie, that was pemetrexed and cisplatin. She had 4 cycles, 4 treatments, but became so sick that she needed to be hospitalized. After the 4th cycle, positron emission tomography scans, or a PET scan, and a fine needle biopsy, which is where they put a small needle into the tumor and pull some of it out so that they can analyze it, confirmed that the cancer had not responded to treatment. For second-line therapy, Jamie's oncologist wanted her to start on immunotherapy medication, nivolumab. Along with her family, she went and talked with her longtime primary care practitioner, who advised her that she stop all attempt at curative treatment and seek hospice care because of the advanced stage of her cancer. So now, Jamie is left to decide between 2 polar opposite approaches to her diagnosis: aggressive anticancer treatment or hospice care. So she didn't really know what to do. So her doctor ordered a palliative care consultation, and Jamie wants to know whether this new treatment can provide the cure she and her family so desperately want. The oncologist tells the palliative care consultant that she hasn't told Jamie about the cost, nor has she explained that even though the related bad side effects are normally mild, Jamie could experience life-threatening effects such as immune-mediated tissue damage and allergic responses. Because Jamie hasn't asked her oncologist about the effectiveness, side effects, or cost of the treatment, the oncologist assumes that all of Jamie's concerns have been addressed. Now, as is true for many people with a new cancer diagnosis, Jamie's gone through a rapid succession of tests and treatment and really hasn't considered her own needs and her own goals of care. So in that consult, when I asked her what her goals are, Jamie cries and she says, at this point in my life, I just want time with my family. My youngest son is getting married in 2 months, and I want to be there. A study by the American Society of Clinical Oncology, we call it ASCO, found that a cancer diagnosis almost triples the likelihood of bankruptcy. According to a study published in the Cancer Epidemiology, Biomarkers and Prevention in 2020, the annual cost of cancer-related medical services and drugs are projected to total nearly $246 billion nationally in 2030. This figure corresponds to a 34% increase in national costs since 2015. These cost estimates include cancer attributable costs of medical services, oral prescription drugs, and These national cancer medical care costs are substantial and projected to increase dramatically, reflecting the rising burden of cancer care among cancer survivors. Most people believe that you get what you pay for, yet findings from cost-benefit analysis have shown no correlation between the price of chemotherapeutic drugs and measures such as survival time and quality of life. Now, the drug that they're recommending for Jamie is nivolumab and has a yearly cost of $187,000. So this drug is $7,194 per infusion, and the infusions are given every other week. It's not curative for lung cancer, and on average, offers patients an additional 3.2 months of life. So you go on this drug, and when they compare how long you would live without taking the drug and how long you would live taking the drug, people on the drug get 3.2 extra months of life. 20% of people will survive 1 year on this medication. And a lot of people hear that. It's like, I have a 20% chance of living a year. But, let's look at it the other way. There's an 80% chance that you won't. And we don't like to think about that other part of it. So still, despite the costs and the risks, some patients with advanced cancer understandably want to try what's this drug, nivolumab, which is called a PD-1 inhibitor, in the hope that it might help beating a cancer death sentence, or more accurately, extending their progression-free survival time. Now, progression-free survival time is that amount of time where your cancer does not continue to grow. The other option that Jamie was offered is hospice support, and you can look at our show notes for previous episodes that we've done about hospice to get an in-depth look at this model of care, because we've done a few shows about it. We also have resources in the show notes about, hospice in general and about hospice eligibility. Obermeyer and colleagues compared two groups of patients with advanced cancer, those receiving hospice care and those not. They concluded that those receiving hospice care had significantly lower rates of hospitalization, decreased use of intensive care interventions, and significantly lower costs in the last year of life. Jamie's struggling with her decision, and so we arranged for a family meeting with her medical team, plus a hospice nurse. At the meeting, Jamie shared her goals, and the team discussed how each would be supported by her options: aggressive treatment, that treatment with the nivolumab, or hospice care. Jamie says she doesn't want to return to the hospital. But she says deciding to stop curative treatment means she'll need supportive care for any symptoms that arise as a result. During the discussion, Jamie appears to be asking her oncologist for permission to discontinue aggressive treatment. In fact, research has shown that conversations about end-of-life care are most effective when they're held with a physician that the patient trusts. Jamie then decides that she wants to receive hospice care at home. The family meeting includes a discussion of advance directives, and all forms are completed. And you can see our show podcast notes related to the topics of, advance directives and that kind of thing. So how can you help family members, friends, or even yourself when faced with the choice between aggressive, potentially burdensome treatment and hospice care, especially if there isn't a palliative care team available to you? Jamie had a palliative care team available, but they're not always available in every hospital or every place you go. What I would suggest is that you understand the risk and benefits of the approaches being offered, and that you ask questions both of the oncologist and of your primary care practitioner. Often, healthcare practitioners assume that if you don't ask a question, it's because you know the answer and you've already thought it through. They don't really stop to think that you're not asking the question because you don't know what question it is to ask. It helps to try to identify personal values and goals that will guide your care choices. Encouraging the discussion of individual interpretations of treatments offered is vital. a simple question such as, what did the physician tell you, can start a conversation that helps answer all the questions that I've talked about and start you on the road to making this important decision. And I'll tell you, that question, what did the physician tell you, is a question that I ask a lot of people, because people will say, well, what do you think about this? Or should I do this? And I'll say, well, what did the physician tell you about that? What did the oncologist tell you about that? Because what I want to know is, what do they really understand about the choices that they have to make? Because then I can clarify if there's sort of a misinterpretation of what's been said, or sometimes it's really hard to kind of pay attention. And sometimes oncologists and physicians can use really big words that you don't want to look stupid and say, wait a minute, I don't even know what you're talking about. And so we don't ask that. We don't say, well, I don't know what that is. And then you Google it, or, look on Facebook and see if you can figure it out. Well, I don't think that making these kinds of decisions are best guided by Facebook, unless you're on our page, and then you can trust us. But, ask the questions. That's what they're there to do. And if they seem rushed or whatever, too darn bad. Too darn bad. You have questions. You need these answers. And then, kind of sort it out and say to yourself, or, talk with a loved one about, well, what is it that you really want at this time? And when I ask that question, people will say, well, I don't want to stay in the hospital. I don't want to use all my time driving to the hospital for treatment. I want to be able to stay home. I want to work on my knitting, whatever it is. And then you say, well, how does each of the options fit into what you're saying that it is that you want? And kind of putting it that way, it makes it a little bit easier for people to say, well, yeah, okay, it's clear this is what I want to do. So, any questions about that, Charlie?
Yeah, I mean, to your point, I just remember with myself, I had what do you call this damn thing? A kidney stone several years ago, and the doctor wanted to try different things. So first I looked up how to deal with a kidney stone, and the doctor then gave me his viewpoints. He gave me some medicine to try to break it up, and it was the nurse who said to me, "Oh yeah, drink water like there's no tomorrow. That could help break it up." So I did that, and I passed this on my own. So when I, did my follow-up visit to the doctor, I told him, I passed a kidney stone. I felt it. And I also they gave me a cup with a little, screen on it so I could pee into that. So I had the stones themselves. Marianne, the doctor looked at me and says, oh, well, you know what? We really need to make sure everything's gone. So, and he started to describe a couple of medications, and he said, and you know what? And then he wanted me to go, was it a CAT scan? I mean, it was something big. I said, but I passed it, and I will keep, drinking a lot of water just in case, there's anything left in there. Oh, no. I want you to take these medicines. We're going to do the CAT scan. I'm not sure it was a CAT scan, but it was something big like that. And I'm thinking, why? Why? And so I just nodded my head. I said, okay, sure. I left and I never went back. And, the kidney stones were gone. I kept pushing the water just in case. But I'm thinking, how many people, because I'd heard it from friends who had been sick, that doctors, to what you were saying, just keep pushing this type of treatment or that type of treatment. And the costs are incredibly high. And it's, a lot of times it just seems like a money-making venture, with the...
I'd be just not to interrupt you, but I am.
Yeah.
I really want to caution listeners about, because what you're saying is exactly what I hear from people so many times, like constantly.
Right. So
they only order that because they only order that because they want to make money, or they only suggested that because they want to make money. Let me give you the reality of the situation.
Okay.
Maybe somebody's making money, but it's not the practitioner who's ordering it. So, and that's that's the work that I do. Like if I order a test, it's because I in due diligence and in following
exactly.
research guidelines, here's what in looking at all the options, here's how you follow this. And at the university, we followed the latest guidelines for how to treat things. And so if people would say, well, or I don't know how much they actually verbalize it to me as you're trying to make money off of me, but I hear about it later from other people, or people are working in my house or whatever. It's like, no, it's not that they're trying to make money. It may be that they're trying to follow the protocol so that if you have problems later, they can't get sued because they told you, I want this, this, and this, and you refused. Well, okay, you refused. You can't sue me later. But they followed the protocol by saying, here's what we should do. And I would put out that, if it's anything nefarious, it's because of people suing healthcare practitioners over a lot of things. So they're not doing it to make money. That's not the motivation, but I hear that all the time. So sorry, go on.
No, that's fine. Yeah, and you're right. You're as always, you're making it much clearer and better than I could. But that said, it is just and I'm sorry, I did not mean to imply that that's what happens all the time. Yeah, it's just that nowadays it seems a lot of times it's there's money to be made at the expense of taxpayers and everything else. And then the other thing too, what you had said at the top about asking questions. You got to ask if you're not sure of something. Please don't be embarrassed. If you want to gather some information beforehand, I don't know, maybe talk to friends or anyone who might have whatever ailment you have.
Do what Charlie does. What do you do, Charlie, when you have questions?
Well, I asked them. What do you mean?
Well, if you have questions about healthcare things, what do you do? Who do you call?
Ghostbusters? Well, first I call Ghostbusters, and then I call you.
Right.
So sometimes it's the other way around, but it's usually that way. It's like I save the best for last, and I call you. Yeah.
It's been like 45 years of, listen, I just have this question about, right, Charlie?
Yes. Yep.
Yeah.
Absolutely. Yeah. Ask questions. And really, if you don't know what somebody, like Marianne said, if you don't know what the doctor or nurse practitioner is talking about, ask them to explain it to you in English, just plain, simple English. Mm-hmm. But you have to advocate for yourself. You got to do it. If you don't do it, no one else will. You have to advocate for yourself. Well, that's it. And I'm sticking to it.
And amen to that. Amen to that.
So in our third half, sometimes there are no words. From Psychology Today, at the time of our final transition from this life, the power of music can be important to provide peace and comfort, not only to the dying, but to family members as well. Research into the use of music in hospice and palliative care has consistently found that patients, family, and staff all benefit from the music, and often after only one session. Music has been found to help decrease anxiety, agitation, and pain. It also helps patients slow and deepen their breath. There is a growing movement to include alternative therapies in hospice and palliative care. Music in these settings has become more accepted and utilized. In 1973, the term music thanatology refers to a specific way of playing music for the dying. But remember, it's the love of your life or a loved one's life, and in reflection, it seems you can't always get what you want. Oh, yes, you can. Sung by the Rolling Stones or played on a harp by your bedside. Hey, it's your funeral. These musicians are trained in the use of music to relieve physical and psychological pain. The patient, if able, can take an active role with the music singing along or playing an instrument. Patients can assemble a playlist of songs they want to hear as they come closer to death. Old familiar songs can help to remind them of happier times and allows them to reflect on their lives and tell their life story. Even if they are in the last few days or hours of their lives and can't speak, there is always music. Remember, the goal of a music vigil is to relieve suffering and to bring beauty and comfort to the dying process, helping with symptoms like respiratory distress, pain, restlessness, and agitation. It can provide support when a patient is actively dying or being taken off of life support. It offers an atmosphere of serenity and comfort that can be profoundly soothing for everyone in the room or on Zoom. Traditionally, a music thanologist plays the harp and sings for dying patients, but traditions are made to be broken. You can get what you want on harp or harmonica. Think of it as the music during the closing credits. You know, it was funny when my mother was dying. She was conscious, but not entirely there. But I would play some of her old favorite songs from when she was in her 20s, and I don't know, she just seemed calmer. It's not like she was awake and all the time coherent of what was happening. Yeah, but just playing that music, just, I don't know, she'd like smile a little bit or her eyes would look a little different. Yeah, and as of the time of this recording, Tony Bennett died a few weeks ago. And it's the same thing. There was one interview with him and his wife, and he looked a little lost. And then his piano player started playing the piano, and suddenly Bennett's face just changed. And he started to sing.
Wow.
Yeah. So.
Yeah, I did a vigil once with a family of one of my patients who was dying, and she loved Christmas music. And so the whole time that she was dying, they had all, Christmas carols going on. So there's no one right way to do that. It's just whatever makes that person happy.
Yeah. There's a radio station out of New York City, and it has different venues, news and all that sort of stuff. And then they have also sections for music, from classical music to American standards and Christmas songs. So, right now, we're in early August, it's hot, and there are these Christmas songs. And I don't know, it's just nice sometimes if I, just scrolling down and I see, some singer I like or a song I particularly like, I'll just click that on. And it's not even about that it's August and I'm listening to Christmas songs, but it's just the songs themselves. They just happen to be Christmas songs. So there you are. And with that, Please stay tuned for the continuing saga of Everyone Dies, and thank you for listening. This is Charlie Navarrete, and from author Mark Twain, the fear of death follows from the fear of life. A man who lives fully is prepared to die at any time.
And I'm Marianne Matzo, and we'll see you next week. Remember, every day is a gift.
This podcast does not provide medical advice. All discussion on this podcast, such as treatments, dosages, outcomes, charts, patient profiles, advice, messages, and any other discussion are for informational purposes only and are not a substitute for professional medical advice or treatment. Always seek the advice of your primary care practitioner or other qualified health providers with any questions that you may have regarding your health. Never disregard professional medical advice or delay in seeking it because of something you have heard from this podcast. If you think you may have a medical emergency, call your doctor or 911 immediately. Everyone Dies does not recommend or endorse any specific tests, practitioners, products, procedures, opinions, or other information that may be mentioned in this podcast. Reliance on any information provided in this podcast by persons appearing on this podcast at the invitation of Everyone Dies or by other members is solely at your own risk.